Welcome to the CodeCast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the CodeCast podcast today. My name is Terry Fletcher. So happy to have everyone here today at the 232nd episode. And today is Top 10 Tuesday, as we are in the last Tuesday of the month. It's Terry Tuesday. And I'm going to continue my series on the 2021 E&M guidelines. Now, I realize we're in 2022, but as we call the 95 and 97 guidelines their own year, that's when they came out. So that's why we're going to keep referring them to the 2021 E&M, and that's for the office visits in the office, mainly because there's so much confusion still. Now, we're on number 12 to 22, but I'm going to go back over number 11 only because it was a tip that everybody said, can you reiterate that? We have a question regarding how to code for prolonged services. Also, it's just fun to look at my stats. And right now, after, again, this is episode 232, I've got 316,000 listens. And so I appreciate that. And we're averaging about 12,350 a month. So just thank you so much for that just continued support and loyalty to our show today. Okay, so let's take a look at some of this information and really figure out, okay, what is it that they're trying to tell us? So I'm going to start back up at number 11. So this is when we get into our top 10. We're going to have 10 today as well. But I'm repeating number 11 because there was a question about, do we have to document start and stop times for the prolonged service? Well, actually, there is on the Internet Manual for CMS, and it's Chapter 12, Section 30.6.15, D as in David. And it says you must indicate and document start and stop times for prolonged services. So I thought that was interesting. It wasn't updated yet on the paper, the white paper internet or white paper manual, but it is on the Internet Manual, and that is the new requirement. I think it's because of the conflicting information that CPT has and Medicare has, and they want to get it right. So question 2, I code the E&M based on time and perform a procedure on the same date. Do I have to carve out the actual time performing the procedure or the fee schedule for normal time? Well, so you need to carve out the actual time spent on the activities relating to the procedure from the time of the E&M services. So the identified fee schedule time is used for pricing the service. So remember, when you look at the fee schedule and you see that they've put time indicators, that's how they price it. That's how they come to their RVU schedule. You're looking at the definitions in the CPT, the AMA book, to find out your time, and then obviously anything that you're billing for in addition. So if you're billing for any kind of diagnostic test, any time it took you to order it, do it, review it with the patient. You can't include that if you're basing your visit on time. And then if you do any kind of minor procedure on the same day, same thing. So you can only get for the actual evaluation and management service. Next question. So this is number 3. Can I count both the resident's time and my time in the teaching physician to choose a levels of service? So this is Medicare's response. And again, all of these responses come from a collaboration of 17 MAC carriers. So just be aware that's there. And I should say 10 MAC carriers and 7 sub-carriers that also work with CMS. So it says Medicare pays for services of teaching physician. Therefore, you would count the time spent by you, the teaching physician. So it's interesting. They didn't just say, no, you can't count both time, but you can only count the time of the teaching physician, not the resident's time. So keep that in mind. Number 4, under the primary care exception, do I count both my time and the teaching physician's time and the resident's time? So under the primary care exception, you would count the time spent by both you as the teaching physician and the resident time. Only count the time once for the time you and the resident spent discussing the patient care. So there is a primary care exception, but I'm also finding like Noridian, if you do that, they constantly ask for records. So it's how often do you want to be audited? Really try and stick to the teaching physician's time on that. Number 5, I requested and reviewed all records from the patient's numerous stays at a facility, one unique source. Can I use the time required to review all the records? So you can count the time you spent in both face-to-face and non-face-to-face time for that patient as long as it's done on the same date as the face-to-face encounter. So it can't be done separately. You also have to document what you did. So the activities of reviewing those records, what you found, and how that contributes to your overall medical decision making. So you still have to have that in there. If you're going to use it as a medical decision making bullet point, then you have to have basically a short paragraph or something that reflects the findings. If you're just going to say, I requested and reviewed all the records from numerous days at XYZ hospital for the patient and determined, XYZ, and this took 29 minutes, then that's the time-based documentation. But if you're actually using it as a review of prior external notes from each unique source, you're still going to have something in there that has more than just a generic statement. What I'm finding a lot of times right now are those generic statements. They're driving me crazy. Very cut and paste. Every single patient has it. And every single patient, I see something like that. It says, I request and reviewed all records from, this hospital. Request and reviewed all records from the patient's previous hospital. You need to reflect how that is pertinent to today's encounter, to specific to that patient, not generically. So please try to get more specific. And then next question. So now we're on number 6. Under the 95 and 97 guidelines, a new patient had to meet the level of 3 out of 3 history, exam, and medical decision making. Is that still valid for new instructions? So know your new rules. The AMA requirements are the same for the new and established patients. You must meet or exceed the level for 2 out of 3 categories of the medical decision making, which includes number and complexity of problems addressed, amount and or complexity of data to be reviewed and analyzed, and then risk of complication and or morbidity and mortality of the patient. Management, which means assessment and plan. The revised 2021 medical decision-making categories are number and complexity. So just make sure you know what that is. Problems addressed. It can't just be, hypertension followed by cardiologist. You get no credit for that. And then if you're going to list your problems, then you have to give the status of those problems. So if the patient is hypertension from a chronic standpoint, you have to reflect if they're stable, why are they stable? Well, patient currently under this medication, patient stable, and give the lab results of the stats on that. And that reflects that you are addressing that problem. So you have to give the status. That's very similar to what we had in the 97. Question number 7. My office uses commercially available tool or electronic medical record, the function to choose a level of service. Can I continue to use that tool to level after January 1st, 2021? So Medicare says there are multiple tools available to assist you in choosing your level of service. The choice of using a separate tool or using your EMR to assist you in choosing your level, basically they said is your choice. However, for Medicare patients, your documentation has to support either the time as described by the CPT code or the medical decision-making table. The EMR may make a code choice, but it's your responsibility to code correctly. So they're not saying you can't use it, they're just saying that good luck. And if you do use it, you're still responsible. Then question 3. Now, some of these questions to me seem a little bit redundant, but they keep coming in and they add them to all of the information. So this one says the medical decision-making table states you must meet 2 out of 3 categories. What does this mean? The levels are straightforward, low, moderate, and high. Documentation must support the level in at least 2 of 3 categories. So you have maybe low number and complexity problems addressed. Maybe you had a low amount of complexity and data reviewed. And then let's say the complications were straightforward. Well, you would be at a level 3 because you had 2 low, 1 straightforward, and so you met 2 out of 3. Another example, and this comes up quite a bit. I have a moderate level of number and complexity problems addressed. So that's typically 2 or more stable chronic illnesses, and maybe I have 1 chronic illness with a slight exacerbation. So that would be starting off with starting off with moderate. But then I've got low level amount of complexity and data. Maybe a lab test was ordered, or there was 1 review of 1 unique test and that was it. That's going to be low or minimal. And then I have high risk of level of what the physician believes is the complications or morbidity and mortality. Well, so I've got moderate, low, and high. Well, what can I meet on that? You can only meet moderate at 2 out of 3. So you've got 99204, 99214. Next, we have, so this is number, 5, 6, 7, 8. So number 8, we have my documentation using medical decision-making shows a level 5. Our time supports a level 2. What will Medicare do? Well, when Medicare evaluates documentation, they'll evaluate based on both. They would accept your level of service when your documentation supports a level 5. We would not compare it against the time spent against the medical decision making. But here's the thing too. Let's put that in reverse, and this is really a big deal. Let's say that your documentation and time supports level 5, but your medical decision making only supports a level 2. That's what's going to be suspect, because you're going to have it's going to be questioned. They're going to say, well, why did something that only warranted a level 2, which is straightforward, minimal risk, and minimal or lack of any kind of data reviewed, why did this need level 5 time, which starts at 40 minutes for an established patient and 60 minutes for a new patient? So was it documented well that it was all about counseling, and why did you need that much counseling, and what was it? What were the activities involved in that? So I think in reverse, that's going to be a problem. And then, this is number 10. Will the medical record still require history and exam? And will the medical decision-making now establish medical necessity? So if you read the CPT book, it still says, the guideline says that you have to have a clinically appropriate history and physical. So documentation must show the medical necessity of the service. And this is the diagnosis or treatment of an illness or injury or treatment of a malformed body member. So your documentation must support the medical necessity of the service and level of service chosen. So why did they come in? What did you review and analyze to determine what they needed? And then what did you do? And was there any risk to the patient on what you determined from your assessment and plan? And that's how you figure out medical necessity of your medical decision making. And I'm going to go ahead and give you a bonus one, this as well. So this could be number 11 on our Top 10 Tuesday. The patient's problem today results in a referral to another specialty. When using medical decision-making to choose the level of service, how do we count this? So you are addressing or managing a problem when evaluating or treating during the encounter. So if you notate that another practitioner is treating without an additional assessment or care coordination, you get no credit. So a referral without an evaluation, and they say by history exam or diagnostic studies or consideration of treatment, does not qualify for medical decision making because you're not addressing or managing anything. So if you address the problem, utilize the level of the problem, and then amount and complexity of data reviewed, and risk to the patient from the referral to assign your category, that's how you get it. So there has to be a reason. Sometimes patients will come in with chronic pain and they'll say, I really need to see a rheumatologist. Can you refer me? Well, if you just say referred to a rheumatologist patient request, you get 0. But let's say the patients and you have a conversation, you as the provider, about the pain and the things that the patient's tried, and Tylenol and Advil aren't helping, and so they have tried stretching exercises, but the patient truly says that they believe they've got some rheumatoid arthritis they need evaluated. And after evaluating the patient for that concern, you say, you know what, I do believe that the patient needs a rheumatoid or needs to have a rheumatologist assessment for potential diagnosis of rheumatoid arthritis, RA signs showing this. So you have to actually work it up to get any credit for referring that patient out. So be aware of that, because I see too many, patient requests, we refer, and that didn't mean you wanted it, it meant the patient wanted it. So to get credit for it on your medical decision making, you have to show how it's qualified, that you actually assessed and gave consideration for that treatment for the patient, that it's necessary for them to have that. Okay, so I do have a coding question today, and it's a PV coding from one of my clients in Massachusetts, in Boston. It said, Terry, a patient had a TAVR procedure, which we know is a valve replacement, and had continued bleeding of the femoral artery. So a femoral artery stent was deployed. What code should I use for this service? I see that the CPT book states 37220 to 37235 are used to describe lower extremity endovascular revascularization services for occlusive disease. So this may not apply, and because this was deployed for hemostasis or to stop the bleeding. How do I bill for this? Okay, so what I would recommend is I would use 27236 for the placement of a stent or stent graft, even though it's in the common femoral. But this is to treat a bleeding vessel. and had this been hemorrhaging vessel been somehow treated with coils, then I would have went to a coil embolization of 37244. If both coils and a stent were used to treat the same pathology, then I would only code the embolization. The code 37226, which is what you're asking about, that's replacement of a stent in the femoral popliteal region for occlusive disease. So you've got a blockage, not for hemorrhage. So 37236 is used when a stent or stent graft is placed for a treatment of non-occlusive disease. So bleeding, a malformation, an AV fistula, an aneurysm, or a pseudoaneurysm, except the iliacs where we use the 34900 code. So just make sure that you're looking also for the Y. We do that a lot in EP as well, in electrophysiology, so that you're coding for ablations, so you're coding this correctly. Okay, our coding question is brought to you today by Citibank Advantage Card. Go to citibank.com to find the right card for you. Start earning miles, points, and benefits from Citibank AA Card today. So my personal tidbit this week, since I pre-recorded a couple of episodes, because of my daughter's wedding, I didn't get to tell you how great it was. So we had just an amazing weekend. She's all married. I can finally take a mental break from all the planning expense and stress. But it was a beautiful and great weekend. And I did post some photos to my Instagram account. So I just hope all of you get a chance to take a look. And thank you so much for the support I've received during this very stressful time. But it was a great weekend. Now I can get back to focusing on what I need to do, which is updating my books, updating some webinars, updating my website. And, my happy place is work. So that's what I'm going to be doing for a little bit. So I'm excited about that before we get full blown into summertime. So, again, we're happy spring. Her name is Summer. She actually was born in winter, which is funny, but she got married at a place where she met her now husband. They got married 1 year from the date of their engagement, and they got married on the first day of spring. So just some little tidbits I thought were cool. All right, that's it for me this week. So make it a great day and a great week, and I'll talk to you next week on the CodeCast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.